The inflamed ureter mouth. The acutely inflamed ureter mouth shows a distinct edematous swelling of its lips. The redness spreads over and obliterates the vessels on the adjacent portion of the fundus. As a result of the pouting of the ureteral orifice, it looks as though the opening were enlarged, though doubtless the swelling actually diminishes the lumen of the canal. Chronic inflammation of the ureter mouth includes 5 changes These surface inflammatory changes, changes in shape, change in function, retraction, and change in the ejected stream. See Plate 1. Surface inflammatory changes. These are similar to the changes of chronic cystitis already described. The ureter orifice may be lost in the inflamed mucosa, or it may appear as an intensely inflamed or ulcerated region in the midst of which the ureter mouth is very hard to find unless dilated. Change in shape. Inflammatory infiltration and cicatricial contraction about the chronically inflamed ureter mouth may cause various changes in its shape. As a rule, the orifice is dilated while the inflammation is still active. This dilatation may make it appear as a long slit or as a relatively open round hole. The earlier cystoscopists used to describe a golf hole ureter, a rigid, round, wide orifice. Such an orifice is typical of prolonged chronic ureteritis, but it is not often seen, nor is its absence any evidence of the fact that the ureter is not chronically inflamed. The golf hole is changed to a tunnel entrance by retraction of the ureter mouth, as described below. Change in function. Just as the ureter may be chronically and severely inflamed without any notable change in the shape of its orifice, so its function is unimpaired by chronic inflammation, unless that inflammation has invaded the muscular coat and impaired its peristaltic action. If this has occurred, the ureter remains still and open while the purulent or bloody urine dribbles from it in a more or less constant stream. Retraction. Retraction, like interference with function, means infiltration of all the coats of the ureter of sufficient intensity and duration to impair the elasticity of the duct and so to pull the ureter mouth upward and outward. Such retraction is often associated with considerable inflammation and ulceration about the ureter mouth. But if this has in large measure subsided, the ureter mouth may be left open, golf hole, and this golf-holed orifice retracted toward the side of the bladder appears like the entrance to a tunnel, with the smooth, pale, scarred, tense trigone appearing as the floor of the tunnel. Change in the ejected stream. Inasmuch as the inflammation about the ureter mouth usually, though not inevitably, implies infection of the kidney pelvis, one may look for pus in the urine ejected. But even though the kidney be gravely diseased, the amount of pus in the ejected ureteral stream may be so little as to be distinguishable only under the best of circumstances as to light, freedom from pain, and freedom from pus within the bladder, which can often not be commanded. Therefore, while meatoscopy, as it is called, i.e. inspection of the ureter mouth, may reveal pus issuing from the ureter, this information is obtained more accurately by ureter catheterism. Any considerable delay for inspection of the stream as it issues from the ureter is worthwhile only when some previous effort has shown that it is impossible to introduce the ureter catheter.